Thank you for joining us today for our Vantage Point interview with Roberta Levy Schwartz. We'll get started shortly and give folks a few moments to get online. I know we have a lot of registrants for today's meeting. We'll start in just about a minute. All right, we're 1 minute past the hour. Welcome, everyone. I'm Denny Brennan, and I'm the Executive Director and the Chief Executive Officer of the Massachusetts Health Data Consortium. We are honored today to have the esteemed Roberta Schwartz here to share about herself and the innovative creation of a number of initiatives, a number of very inventive and innovative operations, transformations. I don't know what to call them. Because they're innovations, they're different. They're like nothing we've seen before. But among them, creating an agile response to the ICU crisis in Houston, which if folks think back to 2020 was one of the epicenters of the pandemic before we had vaccines, before we knew how the virus was transmitted. So we're going to have a lot to talk about in addition to that, as well as the fact that Roberta and I have been friends for a very long time, longer than either of us are willing to say at the moment. But we've also worked together, and it's wonderful to see colleagues do extraordinary things. The people with whom we worked, many of them are in new positions or other positions across healthcare, and it's a great pleasure to be able to reunite about in a new context and to understand what our colleagues are doing, which seems to be pretty great stuff. Before we get started, let me share a few details with you about today's webinar. We will live tweet during the interview and invite you to participate as well using these hashtags and handles. Today's interview will be about 60 minutes in length. We will have time to take questions throughout and at the end of our interview. So please enter your questions into the chat, and we will reply and respond to you during and at the end of the discussion. As you know, the webinar is being recorded and will be available on our website later today. Attendees are in listen-only mode, as I mentioned earlier, so please put your questions in chat. We appreciate your completing a survey, a very brief survey, to tell us how we've done at the end of the presentation, so we can continue to offer great events like this. Let me tell you a little bit about what's coming up at MHDC before Roberta and I start catching up and talking about all sorts of different things. The next MHDC event will be in January of 2023, January 12th at 9 a.m. Eastern time, to be precise. And this is the first in a 12-part series that we call our Executive Forum. It's a members-only event, and we're tackling this whole notion of interoperability. We are, as a consortium, built on the sharing of data among payers, providers, patients, and getting from where we are today to where we need to be is going to be a long and difficult journey. Only yesterday, the Center for Medicare and Medicaid Services dropped their prior authorization rule for public comment, and organizations will be asked to do things as a result of that rule in just one use case, a complex one and a burdensome one nonetheless, that they've never done before. And we're starting our interoperability series, The Road to Interoperability, talking to two of the experts, Alex Muggy, the Deputy Chief Informatics Officer for the Center for Medicare and Medicaid Services, and our friend and colleague, Mickey Tripathi, formerly of the Massey Health Collaborative and now the National Coordinator for Information Technology. So what we're going to have is the payer side and CMS, the provider side and ONC, telling us what this roadmap for interoperability looks like from their vantage point. And we know in healthcare that almost everything that is comprehensive in the way of change starts by way of regulation. People can do extraordinary things if they have a signpost, a regulatory signpost, and we're going to be walking through what those things are over the course of the 12 sessions that we've scheduled for the What is Interoperability series, or the roadmap to interoperability that we've described. So please make note of this address, register, join as a member. This is a members only event, and we make membership easy for organizations, large and small. So please take time to look into our series, learn more about what we're doing, and join us in January of 2023 to learn more about what's happening and how we take this 8-syllable word that means collaboration, digital collaboration, and make something positive about it. And now it's my great pleasure to introduce Roberta Levy Schwartz. Roberta, as I mentioned, and I go back longer than either of us are willing to share at the moment, but Roberta always knew she wanted to work in healthcare. She built a career with roles in health insurance in the Clinton administration, working on health reform, and at the Mount Sinai School of Medicine in New York, now the Icahn School of Medicine at Mount Sinai. Roberta serves as the Executive Vice President and Chief Innovation Officer at Houston Methodist Hospital, where she has worked for nearly 2 decades. She now leads the Houston Methodist Center for Innovation, right at the heart of what we want to talk about, and is leading that research and development team, driving new technologies at the hospital. Roberta, welcome to our Vantage Point webinar series. It's a great pleasure to see you.
Thank you so much, Denny. It is amazing to have lots of old colleagues from APM that are truly doing incredible things. It was a very, very special place that I'm very glad I grew up there.
I feel the same way. I feel like I have a heritage that is shared by just a few people, just relatively few, but folks who have done a lot of amazing things in healthcare. You have been in healthcare since you were young. Could you take us through your background and describe a bit about sort of how you got to where you are and why healthcare is such an important part of who you are?
Yeah, it's true. I'm one of those rare few people who kind of had this crazy concept about what I wanted to do when I was in middle school and high school. That kind of came from candy striping in a hospital in just north of Pittsburgh, Pennsylvania, when I kind of arrived in that area. My stepfather is an emergency room physician, and I have a great uncle who basically my dad, who was who was head of payroll and HR for the Health and Hospitals Corporation of New York. But while I knew they were in healthcare, I really fell in love with the hospital while candy striping there, and knew I never wanted to be a doctor. So set out this course towards administration in the very young years. Through college, I said I wanted to do it. Little bit foreign in a liberal arts world, but went to work in a junior level in a health insurance company, and then really kind of took flight when I went back for my master's degree at Johns Hopkins. President Clinton was elected at that point, and I was able to kind of go down, be part of the Senate and the administration, followed by consulting at APM for about 5 years, where I had my own little journey in the healthcare system. And then basically went to Mount Sinai, and then now have been at Houston Methodist Hospital, I can't believe it, for 22 incredible years.
Well, that's wonderful. I mean, many of us came to healthcare without having any idea that that's where we were going to be. We joined APM and suddenly we were like, I know where I want to be. But before that, that was not necessarily the case. Your experience with healthcare is also a deeply personal experience too. And could you tell us a little bit about, your experience with breast cancer and how that has shaped your perspectives and how that motivated you to do some of the things that you've done?
It is very strange to now have two journeys kind of through the healthcare system and becoming intimate with it. The first was really my own, and that is breast cancer, which I faced at a relatively young age. Unusual, but uh, not that it's not out there. And I was diagnosed at the age of 27, kind of in a very strange way through a OBGYN led to a kind of breast cancer exam or breast exam that was a finding of an aggressive cancer. So I went through this journey. It took about a year to kind of do all the treatment, all kinds of very aggressive things when I was young, including a single mastectomy and then a double mastectomy and reconstruction and chemotherapy and all of those wonderful things that many people unfortunately have the opportunity to do during their lifetime. Um, but probably turned that into a very positive experience when I met a series of young women who had who were also facing the same thing at very young ages. And we formed a non-for-profit organization called the Young Survival Coalition to kind of reach women who were under 40, who were in smaller numbers. So they were out there, but didn't really have anybody in their age group to talk to across the country. And I think that was very impactful. And the ability to kind of turn that challenge into something that was so forceful in its impact has really driven me to recognize that small things can make an extraordinary amount of difference in people's lives. And you can never underestimate the impact that something small, which unfortunately, the Young Survival Coalition has grown pretty substantially. I'd like nothing more than to have it go out of business because there's no need for it anymore. But there are probably about 30,000 young women that it serves across the United States.
That's an extraordinary accomplishment on top of the ordeal itself, to be able to turn that around into a force for positive change for others who are undergoing a similar ordeal. I think that speaks a lot to who you are and what you can do. I mean, there are not a lot of people who think about, I'm alone in this and I should bring together a bunch of people who are going through what I'm going through. And that speaks, I think, as I said, a lot to who you are and what you do. You now lead operations and innovation at one of the nation's leading health systems. And Houston Methodist is a big system with a big anchor hospital. What excites you about your work? What is it that when you show up at work in the morning, after taking care of family things and you're ready to start work, what is it that excites you about the work you do?
It's really an honor to work at a place like this. So I hold two job titles and they're very distinctly different. So on one hand is the executive vice president, where I run kind of our major academic center. The second one is the chief innovation. And I love both of them for different reasons. So when I get to go into my executive vice president, I constantly inspired. If I'm ever having a bad day, all I have to do is go up to the floor and hang out with our staff and walk into a room and help a patient to the bathroom and recognize that what we do is so important and so amazing that we get to be with people in the most challenging times of their lives and make a difference one by one, person by person. It's a very it's a deeply, each person's journey is a deeply personal journey. And to be able to recognize the caregivers and their needs for what they need to take care of those patients, it's amazing. Like I constantly get these stories of what our employees are doing, and I'm in awe, right? Constantly. So again, I get that energy from going up to the floor and in being with them. It's one of the reasons I round every Sunday, and you could really never get me to give that up And it's because on Sunday, there's really nothing between me, the staff, and the patients. And so I get to, I love getting recharged in that way. The second one is the chief innovation officer. And when I kind of got passionate about digital innovation and how it could change and how it could transform, I recognized that in a system that is entirely, not entirely, somewhat screwed up in terms of the administrative aspects of the way we work. And there are better ways to do the work. I this digital transformation that's happening in all areas of our lives and the way we shop and the way we drive and the things that we do. I mean, think about, I'm sorry if people are not old enough, but way back when, we used to sit for a half an hour waiting for a toll booth, our turn at the toll booth, while we waited in these lines. You had the exact change line and the non-exact change line. Now you fly through, right, with an easy tag. And there's ways to do things that are just better and simpler than there were in the past. And I think recognizing that that could come to healthcare, that we could make those differences in my field, and the field that I love and the field that I want to make better, is really what drove me to add this into the portfolio and really both foster and grow new ways of doing things. And so I get that both the personal journeys on one side of my, one shoulder, and I get the transform it on the other. And those two work together beautifully.
Well, we've talked before about, there have been exercises in attempts at innovating or redesigning healthcare that have not gone so well. And it seems that you are working in an approach that is from the inside out. We've seen organizations like Haven. We see Mark Cuban and his work to sort of revolutionize, take apart and reconstruct the whole pharmacy benefits management side of the business. Can you talk a little bit about, when you look at efforts like that, what do you see as being the difference between them and between the successes that you've had?
Anytime I stand up in front of a group in a room full of innovators, on the startup side and the venture side and the everything, one of the things I do is just lavish huge praise and thanks for the fact that they are trying to drive an industry, right? I mean, God bless, Mark Cuban and what he's trying to do. I mean, I think it's great. I think he's, making an effort to change the system. At the same time, those of us who are in the industry, who understand it, who deeply understand our business, need to recognize that there are pieces and parts of that business we can do better, right? And because we know it so intimately, we also know what will work and won't work, what culturally you can move and not move, and at what speed. And you also recognize that it's not always these big fixes, these huge fixes that need to be fixed. Sometimes it's, the little paper cuts. It's that filling in the potholes. It's the making it easier for people. And so when recognizing that it's not just change the whole structure, but sometimes it's just, hey, if you don't store the things in one place, you store them in 5 places down the hall. Nurses don't have to run for an hour back and forth. We're doing one where we're looking right now. It's kind of a stupid one where I'm sure we'll be talking about our virtual nursing and kind of what we're doing there. But one of them is the fact that if our nurses often, when they have to get a blood product checked, it has to have 2 double checks. Really smart, very smart from a safety perspective. But they literally go gowned up and gloved up and they stand in the hallway and they're like, hey, is there a nurse here? Can anybody, hey, can somebody check my, and you stand in the hall and you like scream, waiting for somebody to come into the room. Well, one of the reasons that happens is because the way they set up the computer systems, you have to be at the exact same computer, smart, right? the exact same computer so that no one cheated, right? Someone didn't say, oh, I double checked it when I really didn't. But at the same time, now that you have virtual nursing, they could virtually approve that, but they can't be at the same computer because they're virtually different. So you have to like change the computer system to be able to make it super easy for our nurses to press a button and get somebody in the room within a second. So it's, it's again, it's little and big, and someone from the outside doesn't really know that that's the detail of the way that we practice.
And I think one of the things that you bring up, which is so important and is deeply rooted in my experience as well, is that, culture and workflow, culture and habit crush technology. I mean, they crush the things that we think are innovative. If we don't incorporate those, if we don't incorporate the habits, the workflow, the culture, the way people respond to change and how it really affects their work, favorably or not, technology is doomed. It's very difficult to sort of go into a healthcare organization and say, I have a technological change for that. It's likely not to be what it's advertised as, because it's much more than a technological industry. It relies so heavily on people and everyone making a decision. So I really appreciate that. And I can see exactly what you're saying. Let's go back a few years to a very difficult and very challenging, but also I think an ultimately deeply rewarding time for you. When the COVID-19 pandemic surged in 2020, you oversaw the transformation of Houston Methodist's intensive care services to care for the enormous number of patients that required, ventilation, that required intensive care, and that couldn't be treated by people coming into the room. We were dealing with a virus, a pathogen, a plague about which we knew at that time virtually nothing. Would you describe that experience, what it was, what you accomplished, and how it affected you?
Yeah, I'll take you back even a few years before COVID was even in the twilight of our eyes. And we recognized years ago, and I'm very thankful to a partner, Dr. Faisal Masood, and Dr. And Steve Klon, who are basically in this, as well as Dr. Dalla, who recognized that in the United States, there is an intensivist shortage. You're never going to have enough intensivists to be able to work in a variety of different settings, 7/24, 365. And that was coming. It's like you see the train that's heading barreling towards you at the horizon. And we started seeing that about 5 years ago. And we said, okay, let's begin down the road of pulling in a virtual ICU to support where one person could support multiple different ones of our hospitals and multiple different parts of the organization. So we began down the road and we spoke about talk about cultural, right? How this was going to affect staffing, how this was going to affect how you would interact with the doctor. Just the concept that a doctor could be on the TV is challenging for people. I mean, when you say no, they'll run the code from the TV. It's people grumpy, cross their arms and look at you, and in a very cultural manner. So we started working through that and made the decision. We picked a technology. Super happy about the choice. It was a lighter touch technology than the ones that were on the market, which is sometimes why things get stalled, because the technology is so expensive that you don't go down this road. So, we did that. And we started hanging up the cameras and saying, it's going to happen. It's going to happen. Here we go. We're going to get into it. It's going to affect everyone, but we're going to do it. We hung the last camera on in February of 2020 in 4 of our ICUs in the main hospital. Now, talk about lucking into timing. That is February. If you think about it, we accepted our first patient at the end of February, beginning of March of 2020. And so we were ready. Now, the difference is we hadn't turned it on. And so all of a sudden, we went from fighting people to turn it on to people fighting us to turn it on. And it's amazing again what that timing was. We went from a how could you to how could you not? And we were therefore able, because of that advanced planning, because of doing it a little bit before it was ready, we were able to then really get this kind of started and go out. We went live within 9 months in 7 of our hospitals in every ICU. And to this day now it is managed in a centralized manner. Now, it's different. I think that's different than a lot of people's direct to consumer experience, where you went up to that 80% point and then everyone came back down. Now they're higher than they were before the pandemic. This was able to go all the way up and just stay there. And that's truly transformative. Like we had through COVID, we were able to maintain that transformation and now celebrate it. We've seen a 20% reduction in our code blues in the ICUs, as well as a number of other quality improvements. So we've been able to show that not only did this not harm people, but it helped them. And we're measuring it before COVID to after COVID. We're measuring it all the way through. And we were able to expand and balloon up to from about 125 to about 165 ICU beds using these additional resources.
So let me see if I understand this right, because you got the last camera, which is the way in which you can remotely see a patient in the ICU in their respective unit or their respective room. You have telemetry, which can be monitored remotely, and you must have had to have some people in the ICUs, but you also had a lot of doctors and intensivists who were used to a very, hands-on, appropriately, protected, but no one had to deal with the level of protection that was required here before. The physicians must have been terrified at some point at thinking, how do you expect us to take care of these patients when we're not in the room with them and we can't be in the room with them? What are we supposed to do? And you and your team were able to move those doctors and those intensivists, they're not just physicians, they're nurse intensivists, there are a number of people I don't need to exclude. But like you said, they went from being, why are you having this technology? And when are you going to stop talking about it being turned on, to why isn't it turned on already? What was it, what was it that made them change their minds? What was it that made them feel like they could rely on you and what you and your team were doing, and do things in a way that was completely different than they had done them before, and better? That's an incredible transformation. Now that's taking the nurse with the blood looking for the second nurse to come and validate what's done and expand it by a substantial number. How did these people get brought along? What was the motive force that made people say, we can't do this to we can and we must do this?
We did have a few. I will say there were probably 3 motivating forces, and COVID was definitively. I mean, it was very strong motivator. So you had 3 things. Number one, we had a few physicians who would moonlight or had done virtual ICU and were very strong supporters of it. So I think that was excellent. And the group that we contracted with, there were a few doctors that we knew from that group that had either been here before or were known to our group and really did a good job of kind of coming in. The second one was that it was going to cut down a lot of night shifts for our doctors. And I think they were incredibly motivated. We used to have 4 doctors in house every night, and everyone was motivated to sleep, which God bless, they should. So they were going from almost, 2 times to, they were cutting down by 50% the amount of night shifts they would have to do. So that was a second motivator. The third motivator was, even if they were intensivists in the ICU, to not have to go into the room every single time to do those visits during COVID was a pretty strong motivating force. The families couldn't come in. There were ways to pull everybody in. And let me take this a step further, because your question's really good. And we're doing it right now, yet again, and probably even in between our prep and now, we've now gone live with virtual nursing. So talk about yet another population and the same thing, where we came in and did a time study and found that our nurses were spending, which everyone knew, right? 40 to 50% of their time documenting. And the question was, in a shortage of nurses, like your shortage of intensivists, how could you change the dynamic and get that paperwork done in a more efficient manner so the nurses you had on the floor could be better utilized to do what they needed to do? And that virtual nursing pilot is, I wouldn't say it's a pilot anymore. We're live in almost 600 beds, and it is so well received by our staff. And they've gone from the beginning of it saying, how about you bring us a real nurse, to this is the best thing you've done for us in a long, long time. It takes almost 10 days to go from introduction to this is great on the unit. And it's now 4 months later on the units that started it kind of at the beginning. It's a well accepted, like, this is the way we do business. And the amazing part to me to go up to places is like, right, you and I remembering toll booths. People are like, wait, oh yeah, I remember that. And I'm less than 6 months between having the first virtual nurse, and people are going, oh yeah, wait, we didn't have them 6 months ago. Like, they can't actually even remember, which I find absolutely hilarious. I'm like,
Well, it's very
it's only
gratifying too.
July. Like, that's pretty new.
Well, what is a virtual nurse? I mean, it begs the question. Tell me what a virtual nurse is.
So they do all the paperwork. When the patient walks in the room, they get handed, that iPad, and the nurse walks in and says, I'm going to hand you your iPad, and the virtual nurse is going to come on and do all of your admission paperwork. And she does the whole nursing assessment, all of the fields that need to be filled out, which previously took a nurse about 40 minutes because they got interrupted all the time. Takes our virtual nurses about 13 minutes. And we do the same thing on discharge. So now we're looking at different ways that they can be used in the middle, i.e. double checks, education, hourly rounding, lots of other things. They basically help when nurses on the floor are stretched. They're really helping be the arms and, arms on the educational and documentation and helping front. So it's pretty amazing. And again, beloved at this point by our staff.
That's exceptional. Tell us about the Center for Innovation at Houston Methodist. Who's in it? What do you do? What are some of the projects? I don't want you to give away the store, but what are some of the projects that you're thinking about in this center, and who are the people you needed to bring together to make it work?
So as we said in the earlier part, right, there are big problems, there are small problems. And what we were watching was this digital transformation. And one of the fun parts is that it started, as I said, kind of with the Young Survival Coalition, same thing, which started as, it was supposed to be a newsletter, getting young women together. It turned into this huge organization. That's a lot of how I feel about the Center for Innovation, which was really started as a journal club. We brought it together. I didn't know what to put on the invitation to invite everyone to this journal club. So I put the digital innovation obsessed people. And so today it still lives on all of our coats that we wear when we go out and give talks as DIOP, digital innovation obsessed people. Only probably about 18 months into it, as we realized how important it could be, did it really get its own name as the Center for Innovation. But we bring together all the different units. So our physician organization, HR, hospital operations, supply chain, everyone kind of comes together on the operations and IT on kind of two sides of the circle that complete the circle, to basically say, how in small and big ways can we transform our processes? And so things come into their care redesign. It's big. We've been out there talking about the work we're doing in care redesign. So that includes a lot of this work we're doing with virtual nursing, but it also includes ambient intelligence technology, kind of like self-driving cars or easy path. It looks at the environment within the room or the operating room, and it says we can actually watch that and provide intelligence on what's happening in the room to guide our staff about how to improve efficiencies, how to do things better, i.e., patient hasn't been turned in 4 hours. Someone needs to go in and turn them, and I'm going to alert you to go do that because there's no movement. We're looking at remote sensors to do vital signs. We're working with our HR partners to provide a Domino's pizza-like approach to our hiring activities. We've been working with intelligent locations to track people, places, and things in all areas of our facility and make life better for our supply chain. Our physician organization heavily working in access, incredible on how to use texting in patient experience, how to communicate with folks at the right time in the right places. So we have work in almost every different area of our organization. And because we split it up, we don't have this roadmap that's like, oh, we're going to do this first and this first and this first. What we find is there are different teams that can all work at the same time and don't overburden our IT staff. We're watching then, therefore, our care redesign work and now porting that over into the physician organization, looking at our MAs over there, and we're taking their access work and porting it over into the hospital. So it's really amazing now to look back on how many projects we've touched, but each one belongs to operations, right? They belong to an operational owner. It's not happening somewhere off to the side. And when different organizations come in to study how we're doing things at Houston Methodist, what they all say is, oh, I get it. Your operations is fully involved. So when you say you're going to do something, they have to make it happen. And I'm like, well, how else would you do it? Like, sometimes they don't understand what we're doing and I don't understand what they're doing, but we're engaged. Like our operations has to own the price tag because if it's going to have a return on investment, they should be able to pay for it. We push it out there. We'll get it started. We help roll the ball uphill, but then when it gets to a plateau or when it gets to a place where it can get easier, it's over to operations. Like virtual ICU, these things are not owned by the Center for Innovation. We own like 5 resources. Like that's it. And
you're like an incubator.
Exactly. We just help you. And the nice part is because I've got an operational hat, sometimes I get to try things in my own operation.
Well, we're at a time now where, in addition to improving the efficiency and the effectiveness of the healthcare delivery system, we have to adapt and improve the way in which the health system works with respect to people who have been historically disadvantaged. The move to improve equity and access and the patient experience, they need to apply to all patients. And a lot of the technologies that are used are sometimes inaccessible for patients with disabilities, as an example, or inaccessible to patients for whom those technologies can be either unavailable from a financial perspective, or there's a level of literacy that needs to be reached before they can use them effectively. How has the push to create a more equitable health delivery system affected your work at Houston Methodist? How do you adapt and accommodate and provide the services, the accommodations to those who have historically had a harder time, much harder time in some cases, getting the healthcare they need?
I think that it is an exciting time right now if we take the opportunity of what we know and be able to bring it to many people who may not have had the same opportunities. In that telemedicine and the ability to port healthcare to your phone is it's somewhat of an equalizer. And I find that you can get into communities that you couldn't previously get into who may not be willing to come to you in a way where you can bring care to them. And I think that where some people would say we're already there, but I would say that we're just beginning a remote monitoring revolution that will help us to identify who needs to come and who can stay home. And if they can stay home, what can we do to support them in a much better way to stay there? And I'm enthusiastic about the ability for technology to help us not just rely. I mean, if you think about a while ago, our most exciting innovation was, well, we'll send a van to pick you up. And I'm like, I appreciate that, but how come everything has to be at our place in our way? If patients live 3 hours from here and they just are doing a check-in with their physician on a level, how can we not have them draw that level where they are and our physicians remote in to explain it to them and not have to have them come 3 hours from a community into us to get the care that they needed? And keep those, a visit generally on a remote visit is about half the amount of time. So save that other time to open up more access. And in a place where you are challenged to be able to get the resources for enough people, you have a shortage of doctors, you have a shortage of specialties. In those areas, how do you take that precious resource and spread it at a wider level? And I think that's going to be the promise and the hope of both the technology to get people there and the remote monitoring that is starting to come into the marketplaces.
Suzanne asks a great question, which is one that I was thinking of myself, which is, and we used to talk about this when we did redesign and re-engineering and trying to get hospitals and health systems to be more responsive to, changes in patient acuity, changes in patient mix, changes in dealing with, the shortages of physician and nursing, all sorts of factors. Right now, and we're seeing this significantly in Massachusetts, we have a labor shortage. We have, an increase in ICU utilization, especially by children for respiratory diseases, not necessarily COVID, but a big jump in that. And, one of my sort of APM reactions to that is, how do we get out there and help them? How do we, we can't expect these folks to come to the hospital, the house on the hill, or, the big institution. We have to get out there and get to them, which bodes some very profound changes for healthcare delivery going forward. What do you see healthcare looking like in 20 years? What do you see? You have a very large system and you're looking at moving further out into the community. Does that disaggregate you? Does that deconstruct you in some way? What does healthcare delivery look like in your mind in 20 years?
I don't think any of us 20 years ago would have thought that Amazon would be the thing in our lives that it is today. And I wish I could look out 20 years. I'm trying to get 2 to 3 years out there because one of the things we're doing in our smart hospital, I keep telling people it's not about the technology I've got today. Like all that technology will go into that hospital, right? No problem. Our Cypress hospital is designed, but what it's designed for is what's behind the walls. So what can I get up there that I don't even know about today? Like what is somebody going to come up with that's going to have 3 plugs, 2 data drops, no data drops, more wireless? So it's funny. It's the infrastructure I'm putting behind the walls to be ready for it. And I think that's going to be one of the hangups for hospitals today. Retrofitting into a lot of these technologies is very difficult. I can say, and I'll put on the table, I believe, I'll put a few things that we made bets on and introduced these earlier this year, kind of our bets about the future. I'm going to bet that within about 5 years, almost every acute care room has a camera. I think that people are going to start to have hubs of, years ago, it was kind of Mercy that had the only hub. I think you're going to have to see more and more of those nodes. And I think it's possible that those nodes will get centralized. Little devices like this, I mean, this is hopefully by next year going to do all vital signs within our organization, right? That's going to change the structure of the workforce. So we're going to see more and more of these devices. I saw one that I looked at the other day, and I kept turning back to the PowerPoint because it was bloodless glucose levels. So i.e. a sticker that you put on somebody that would tell you what their blood glucose level was without finger pricking. And I was like, that's pretty big. That's pretty interesting. So like, i.e. I could wear my iWatch and be able to tell what my blood glucose level would be. Wow, that's like, those are the things that I don't know that I can look out 20 years. Do I think that hospitals have the potential to be smaller? Yeah. But hospitals are always going to be needed. We already are growing our CMI. Like, we're already becoming more and more intensive care like. I mean, each one of our hospitals has become more and more complicated. You're getting this stronger differentiation between those things that can be done outpatient, extended recovery, go home, and those things that you're having patients stay for a very long time. But the idea that we could 3D print organs, send organs via drone, I mean, it is, if I do too much thinking about 20 years, I am almost so blown away that I can't get started on the projects I need to get started on. So love the question. It's exciting to talk about. It also kind of freaks me out.
Well, I have the same reaction. I sometimes think 5 years is, a long time ago, I thought 5 years was, a long time. And after being in healthcare for a while, 5 years is a long time. I mean, you have to, for the kind of changes that we talk about, when someone says it's going to take us 5 years, I used to think, why so long? And I've grown to appreciate that, real success, especially at the level of how people work and how people learn and how patients get engaged, doesn't happen overnight. One of the questions that comes across frequently, and let me ask this question first. Tell us about this new hospital. Tell us about this Cypress Hospital, this new version that that Houston Methodist has put in place. Tell us what's different, what's there.
So, we will go live in that hospital with cameras in each one of the rooms. I mean, every single one will be ready for remote monitoring. All of the data gateways will be in place. I will tell you that we're building it with much smaller kind of traditional waiting rooms, because we do believe we'll be able to bring people right from car to treatment room without much sitting in, with all the technology of being able to contact them. We're building in the places for remote monitoring to happen, because again, one of the things remote monitoring does, which is gorgeous, is it removes geographic boundaries. Many times getting a nurse to go from one floor to the next in the middle of a shift, or help out 2 patients one place, 2 patients in another. When you remove geographic boundaries, you're able to cross over many things, which is a pretty interesting way to look at issues. We're looking at places where even physicians can do the come to a central location and be able to round the hospital without moving, and being able to round differently. So those are some of the issues we have. But again, it's a lot of behind the walls work on, the speed of movement, the wireless technology, the wires that are going behind the wall, to be able to be ready for whatever's coming next.
Healthcare tends to operate in silos, as you and I have known for a long time, both in terms of the responsibilities and projects, in terms of data, in terms of people's professional identities and their job, the scope of their work. How do you see your organization and healthcare in general starting to connect these teams? You've done that. What have been some of the ways in which those connections between people, process, and technologies that used to be pretty hard to forge, especially with people, are starting to happen? How do you begin to centralize or organize historically disparate groups, disparate processes, disparate data into more useful integrated wholes? How do you go about it? What's some of the lessons that you can share with us about de-siloing, for lack of a better phrase?
I'll actually connect your question to one of the ones I see in the chat, and I'll pick up a new stream that we haven't talked about at all, which is kind of the area of AI and predictive analytics. And we've had the opportunity to work with two companies that, and as I'm trying not to do advertising, I can't, I love, and one was the company we worked with to build out our virtual ICU, and MIC basically sucks in all the data from every one of our machines and all of our labs and everything from Epic, and puts them together and built out the predictive analytics for our virtual ICU. But what they recognize is with this depth of data and the data scientists that they have, we could start to predict what patients needed to come to us from our community hospitals. Rather than being a push strategy, we know we need help. It's the pull strategy of, now we need you. We see that you need us, even though you say you don't, right? You belong here and you belong there. And we're watching some of our intensivists now build out those protocols. And we then, between that, and then we have another group that we've started to work with, HDAI, that has kind of 15 to 20 years of Medicare data that we're digital twinning our data and looking at predictive analytics. In both instances, what we found is that we always have one or two groups that like suck in. Same thing when we did care pathways with a company called CareSense. We have one or two groups, ortho, cardiac, somebody digs in first. And we don't always look for whether or not that's the biggest return on investment for that technology. We'll say, if it's got a good return and it's like an evangelical group, then basically you go first. And it's like watching the first kid go into the water and say, the water's not so bad, it's not too cold, like you can come in now. And we use them to evangelize the community. We'll show their outcomes and use that to go across and start to move the culture. It's interesting now, as you say, 5 years, 5+ years into the journey, I joke that CareSense, which is a technology company, is for us a noun, a verb, an adverb, for some physicians, maybe even a swear word, but that's fine, right? It's a way to get things done. We view that the same way in the work that we're doing with all of this predictive analytics, and allowing our physicians to recognize the power of it, because for the first time, they actually have incredible clean data and data scientists that are willing to work with them, and the excitement of it. But in the same way you asked me the question, what's coming 20 years from now? It's an overwhelming question to me, right? For some of our physicians, the amount of data that is now out there that they can use is an overwhelming amount of data. And so getting people to break it into chunks of what they know and how they can harness it is pretty incredible. And to watch the physicians who are using that, it's pretty amazing. So I love the work that's happening around the country, and I do hope that we will share that, and we will share the knowledge to make us all better, because our industry and our care just needs to improve.
We have a question from Megan, who asks about human-centered design, and how do you apply that to your innovation process? Do you have dedicated user experience researchers, designers? Do you rely on third-party partners to help you? How do you draw people to the technologies that you're using and improve the experience of the user in using those technologies?
So we do not have human-centered design people, and every once in a while we'll use some, but one of the things we do is we'll roll it out in one place with the assumption it's going to be great going across the organization. But we roll it out and then we listen very closely to our end users. What works, what doesn't work, what would you like to see, what wouldn't you like to see, how could we make this better? And because we're rolling it out generally with our own people, we have iterations that go very quickly, shift by shift, hour by hour, where we're improving that. And because of that, we're able to make the changes very quickly and adapt. So like one unit said, and it changes depending on which unit you're rolling out. So we rolled out the discharge process in urology, and they said there's too much teaching. You're not getting this. So where arrival and admission was a home run, the discharge process was only a double. And so the question was, how do you take the people in the virtual and train them to be able to help people? Or do we do the teaching earlier in this day, so when they're ready for discharge, we're not doing it? So with each unit, we give it time to adapt and adjust what gets done to make it work for them. So this end user input has been pretty critical. And again, that's where we have these butcher papers of what's next, what would help you the most, what do you think would be the next process to be a home run for you? And so that's where we're working on stupid things. I mean, double check is probably not going to have the biggest ROI, but it's a huge annoyance for our folks. And that's the same thing we do in virtual ICU. Same thing now. I mean, even intelligent locations. We sent one of our fellows to look on Google and find the best, case studies that are out there anywhere in any hospital on supply chain, and went back to intelligent locations and said, could you do this? It's really interesting how low tech and high tech on human-centered design both work.
We have a question from Schlumit, who says, fascinating talk. Any thoughts about harnessing technology for disease prevention?
When we look on the inpatient environment, one of the biggest questions you have is, can you prevent people from progressing, right? So especially if I'm looking at a vital sign technology, one of the things that it's doing is it really looking at whether or not you can see the issues earlier and prevent people. Can you see that temperature was already having starting to rise long before every 4 hours, every 8 hours? Can you see that rise in the vital signs? Now, if people go home on remote technology, can you do the same thing? Can you get that information in advance of something happening? I love the fact, years ago, University of Chicago had done an algorithm and had basically said, we can probably tell whether you're going to have a heart attack tomorrow. And the answer was, okay, wow, if you can figure that out, what can you do about it? And I think we're in that initial phase of being able to use the technology to watch trends. And then it's very important that we close that loop and figure out what to do about it, how to coach, how to monitor. And that is one of the differences that we're doing, is watching this on an inpatient environment so we learn how to monitor, and then we can apply it in the outpatient world. I think there are some companies that are doing a great job in this on limited amounts of diseases, like watch diabetes, incredible what the work of people like Livongo or My Sugar or other people are doing. But again, it's very limited and it's very focused, and we're looking to broaden it to multiple different areas all at the same time.
Well, Roberta, we're coming to the top of the hour. We have about 30 seconds. Are there any parting words or any thoughts that you might leave us with today before we wrap for our discussion?
People make the assumption that you need to have some huge title and some huge part of your organization to get started on innovations. And I would say that there's big I and there's little I, and don't forego how much difference the little I's will mean in pennies add up. And it's very important to get started and not to be afraid of it.
Well, Roberta Levy Schwartz, Executive Vice President, Chief Innovation Officer for Houston Methodist, I want to thank you for joining us today. It's lovely to see you again. It's great to talk with you. I could talk with you for hours, but I know that we have a time limit. And I want to thank you again for sharing your experience with us in our community. And we'll be following and seeing how things progress for you. Those of you who are on the call.
Thank you.
Oh, you're welcome. And those of you on the call, please take a moment to complete the survey as we sign off. But with that, Roberta, I'll thank you, and we're adjourned. Take care, everybody. Bye-bye.